All right, let's dive into a topic that can be a real diagnostic headache in gastroenterology, but one that is absolutely crucial to get your head around as a trainee: those hidden, sneaky anatomic anomalies of the pancreas. So let's set the scene. It's a common one, right? You're on call, you've got a patient coming in with their third, maybe fourth bout of acute pancreatitis this year. You've done the workup. You know it's not gallstones. You know it's not alcohol. You've hit a wall. So what's next on that differential? This is exactly where the real detective work starts. Before we go hunting for the really interesting stuff, the zebras, we have to quickly run through the usual suspects, the things that should be on every single initial workup. Yeah, we're talking about the big ones: gallstones, alcohol, crazy high triglycerides, maybe certain medications. You also have to think about whether they just had a procedure, like an ERCP, or if there's an autoimmune thing going on. These are your bread and butter, the first things you methodically rule out. But what happens when the labs come back clean and the history doesn't give you anything? Your patient is still in pain and they're looking at you for an answer. This is that critical pivot point, you know? It's where we stop looking for the common things and we start thinking, okay, could this be a structural problem? And that's when these anatomic culprits have to be on your radar. These are congenital variations, literally things people are born with, that might not cause any trouble for decades. We're talking about conditions like pancreativism, annular pancreas, or maybe a weird connection between the ducts. These are the hidden players that often explain so-called idiopathic pancreatitis. Okay, so now we are officially in zebra country. These are the diagnoses that are easy to miss, but when you find one, it can be the key that unlocks the entire case for your patient. At their core, the problem with these anomalies is pretty simple. They're basically plumbing issues. Seriously. Things like pancreativism or an annular pancreas are just differences in how the pancreas was formed, and that can lead to blockages. Just think of it like a kink in a garden hose. The pressure builds up behind that kink, and that's what causes the inflammation and the pain. Which, of course, brings us to the next logical question. It's one thing to suspect a structural problem, but how on earth do you actually find it? How do you prove it? Your standard imaging might not cut it. We've got to bring out the heavy hitters. So, in this next section, let's walk through the advanced diagnostic tools that really let us see these small but incredibly important anatomical variations. And let's be clear, we're not talking about a simple blood test here, or even a standard CT scan. To unmask these anomalies, you need to get a direct, super detailed look at those pancreatic and bile ducts. This is really the world of advanced endoscopy. One of our most powerful tools is endoscopic ultrasound, or EUS. This gives us an incredibly detailed, high-resolution picture of the pancreas. And we use standardized criteria, like the Rosemont classification you see here, to look for subtle signs of chronic inflammation. Finding these little changes can be your very first clue that there's an underlying anatomical issue driving the whole process. Now, EUS is a fantastic diagnostic tool, no doubt. But really, the gold standard for both locking in the diagnosis and potentially treating the problem is ERCP. That procedure lets us get right up to the ducts, inject dye, and basically draw a live roadmap of the plumbing to see if there's anything unusual. But here's the catch. When you're dealing with abnormal anatomy, just getting your instruments into the correct duct during an ERCP can be a huge challenge. This is what we call difficult cannulation. And honestly, the fact that it's so difficult can sometimes be a diagnostic clue in itself, pointing you towards something like pancreativism. And that is exactly why advanced endoscopists have a whole bag of tricks to get the job done. We're talking highly specialized skills like the double guide wire technique or using a needle knife to make a new opening. This is definitely high-level, technical stuff used to gain access when the normal way just isn't working. Okay, so you did it. You put in the detective work, you found the hidden culprit. That's a huge win. But now, what do you actually do about it? Let's talk management. The management is comprehensive. It's a real team effort. The goals are pretty straightforward, though. We want to support the patient with lifestyle changes, get their pain under control, and treat any immediate complications like cysts or blockages. And then long-term, we have to keep an eye out for pancreatic insufficiency, trouble digesting food, or even the development of diabetes. For the root problem, the structural issue, our major interventions really fall into two big camps. You've got endoscopic therapy, which focuses on relieving the blockage in a less invasive way, maybe by cutting a muscle or placing a stent. And then you have surgery, which is obviously a bigger deal but aims for a more permanent, definitive fix, like completely rerouting the pancreas's drainage system.
We have covered a ton of ground, so let's wrap it up and boil it all down to the key things you need to remember as a clinician in training.
If you only remember one thing from this whole explainer, please let it be this. When you have ruled out all the common stuff and you're about to label it idiopathic pancreatitis, stop. Your very next thought should be about the structure. Always, always think anatomically. So here's your cheat sheet for rounds tomorrow. You see idiopathic recurrent pancreatitis, you start the workup for an anatomic cause. Your big tools are EUS to investigate and ERCP to diagnose and treat. Knowing what's possible with these advanced techniques is huge. And finally, remember that taking care of these folks is a long-term, team-based marathon, not a sprint.
You know, in medical school, they drill into us, when you hear hoofbeats, think of horses, not zebras. And 99% of the time, that's great advice. But in the workup of recurrent pancreatitis, sometimes the patient really does have stripes. You can't be afraid to hunt for that rare diagnosis, because finding it can absolutely change your patient's life.
So, the next time you're faced with this puzzle, and you will be, you'll have the tools to look deeper. The only question left is, which hidden diagnosis will you be the one to uncover? Thanks for tuning in.